All right, let's dive right in. Today, we're tackling a topic that is, without a doubt, a cornerstone of both emergency medicine and cardiology: cardiac arrhythmias. You know, getting this stuff down isn't just about acing your exams, it's about making split-second, life-saving decisions when the pressure is on. So let's break down the most critical, high-yield points you absolutely need to master.
And why is this so critical? Well, because it doesn't matter where you are, in the ICU, the ER, on the general wards, or sitting in an exam hall, understanding arrhythmias is completely non-negotiable. This is the kind of knowledge that truly saves lives and, yes, scores a ton of points.
So, what are we really talking about here? At its very core, an arrhythmia is just a problem with one of three things. It's pretty simple, really. Either the heart's rate is off, too fast or too slow, or its rhythm has gone haywire and lost its regular pattern, or number three, the electrical wiring itself, the conduction system, has a block somewhere. If any one of these is out of whack, you're dealing with an arrhythmia.
Now, to really understand what goes wrong, we first have to be rock solid on what normal looks like. So let's take a quick moment to build that foundation by reviewing the heart's incredible electrical system.
Think of the whole process like a perfectly timed electrical cascade. It all kicks off in the SA node, which is the heart's natural pacemaker, setting that nice baseline rhythm of about 60 to 100 beats per minute. From there, the signal zips across the atria to the AV node. Then it's like a superhighway down the bundle of His, which splits into the bundle branches, and finally, it activates the Purkinje fibers, and that's what triggers that powerful, synchronized squeeze of the ventricles. Every single step in this pathway is absolutely crucial.
I love this mnemonic. It's a classic for a reason because it perfectly captures the two most important jobs here. The SA node sets the pace, sure, but it's the AV node that introduces this critical little pause. And why does it do that? Well, it's to give the ventricles just enough time to fill up with blood before they're told to contract. It's just a brilliant piece of biological engineering, really, making sure you get the most bang for your buck with every single heartbeat.
And here is where physiology meets pharmacology, a concept I can almost guarantee will pop up on your exams. The phases of the action potential line up directly with how our antiarrhythmic drugs work. Take phase 0, for instance. That rapid influx of sodium is exactly what class 1 drugs target. Then you have phase 2, where class 4 drugs come in to block the calcium channels. And in phase 3, class 3 drugs block the potassium from leaving. A fantastic way to remember this is the mnemonic some block potassium channels. S for sodium blockers class 1, B for beta blockers class 2, P for potassium blockers class 3, and C for calcium channel blockers class 4. Getting this connection is absolutely key.
Okay, so with that electrical foundation solid in our minds, let's turn to our number one diagnostic tool, the ECG. I know it can look a little intimidating, but trust me, with a systematic approach, you can decode any rhythm strip with confidence.
And this right here is that system. You have to follow these 5 steps in this exact order every single time. No skipping around. Start big with the rate. Is it fast? Is it slow? Then check the rhythm. Is it regular or is it just chaotic? After that, you zoom in. You analyze the P wave for atrial activity. You measure the PR interval to check on the AV node. That should be between 0.12 and 0.20 seconds. And finally, you check the QRS width to see how the ventricles are doing. It should be nice and narrow, less than 0.12 seconds. Using this system keeps you from jumping to the wrong conclusions and missing really important clues.
So let's put that system into practice. What's the most common arrhythmia you're going to see? For sure, it's atrial fibrillation. If you use our steps, you'd notice a variable rate and, most importantly, an irregular rhythm. The second you see a rhythm strip or feel a pulse that has absolutely no pattern to it, it's just pure chaos, your brain has to immediately scream AFib. And remember, this isn't just a rhythm problem, it's a huge risk factor for stroke, which is why managing it is so important.
Okay, now that we have the fundamentals of diagnosis down, let's start talking about management. We're going to kick things off with the bradyarrhythmias, the rhythms that are just too slow.
So you've got a patient with symptomatic bradycardia. That means they're slow and they're showing signs of trouble, like dizziness or sinking blood pressure. This number is your first move, 0.5 milligrams of atropine IV. What atropine does is it blocks the vagus nerve, which basically tells the SA node, hey, speed it up. You can give this dose every 3 to 5 minutes, up to a maximum of 3 milligrams. If that doesn't work, your next step is pacing.
Now for a classic point of confusion, the second-degree AV blocks. Let's look closely here. Mobitz I, which we also call Wenckebach, has this predictable pattern of longer drop. You can see the PR intervals stretching out with each beat until, poof, a beat is missed.
But MBBS 2, that one is way more dangerous. The PR interval stays the same, it looks fine, but then, out of absolutely nowhere, a QRS complex just vanishes. This one can quickly turn into a complete heart block, so you have to take it incredibly seriously.
All right, let's flip the script and talk about the exact opposite problem, tachyarrhythmias. This is when the heart is just beating dangerously fast.
This slide is pure gold for your exams. It's a rapid-fire summary of your go-to treatments for fast rhythms. Let's run through it. For a stable SVT, your first drug is adenosine. For good old atrial fibrillation, it's a two-part strategy. Control the rate and prevent clots with anticoagulation. For a stable ventricular tachycardia, you're going to use amiodarone. Now, for the chaotic and deadly VFib, there's no drug first. You defibrillate immediately. And finally, for that unique twisting pattern of torsades de pointes, the answer is always magnesium. Now let's zoom in on a couple of key doses from this list.
When you see that stable, narrow complex tachycardia, SVT, this is the number you need to know. 6 milligrams of adenosine. And you have to push it super fast through an IV because it has an insanely short half-life. It basically works by hitting the reboot button on the AV node, stopping that runaway electrical circuit. If the first dose doesn't cut it, you can follow it up with a bigger 12 milligram dose.
And for torsades de pointe, which you'll spot by those classic twisting QRS complexes on top of a long QT interval, the specific antidote is magnesium. It works by stabilizing the cardiac membrane, just calming down all that electrical instability. The standard dose is 2 grams IV.
And now we're moving into the highest stakes scenario of them all, advanced cardiac life support, or ACLS. This is where knowing your algorithms and your doses inside and out is absolutely, positively critical.
The entire cardiac arrest algorithm splits right down the middle based on this one question: is the rhythm shockable? And as you can see here, the only two rhythms you can shock are VFib and pulseless VTach. The non-shockable ones are asystole and PEA. This single distinction determines every single move you make from here on out.
Okay, so you're on the shockable side of the algorithm. You've delivered a shock for VFib or pulseless VTach, but the rhythm is still there. Your first-line antiarrhythmic drug is amiodarone, and this is the critical dose you must have memorized, a 300 milligram IV bolus. You're usually giving this after the second shock doesn't do the trick.
And now for the one drug that's used in every single cardiac arrest. Doesn't matter if it's shockable or non-shockable. Epinephrine. It's a powerful vasopressor that helps crank up blood flow to the heart and brain during compressions. The dose couldn't be simpler. 1 milligram IV, and you repeat it every 3 to 5 minutes for the entire code. It is the absolute workhorse of ACLS.
Finally, let's remember that great arrhythmia management isn't just about reacting to a crisis. It's about preventing one in the first place. And that means excellent, proactive care. You need continuous cardiac monitoring for any patient who's at risk. You have to be obsessive about correcting electrolyte problems, especially potassium and magnesium, which can easily trigger deadly rhythms. And of course, you always make sure that Crash Cart is stocked and ready to go, so you're prepared long before an emergency ever happens.
So how do you get truly comfortable with all of this? The answer is right here. There are no shortcuts. The secret to mastering arrhythmias isn't just about memorizing facts. It's about pattern recognition. And that only comes from one thing: consistent, daily practice. Make it a habit. Look at one new ECG every single day.